So the current approval from the FDA that just recently happened has really identified that we can move pembrolizumab earlier in the treatment course for patients with relapsed or refractory classical Hodgkin's lymphoma. So the pivotal data that looked at pembrolizumab had established the role of this treatment in a group of patients with classical Hodgkin's lymphoma that will have relapsed after autologous stem cell transplant, and usually would have required some treatment with other agents such as brentuximab, or patients that had been ineligible for autologous stem cell transplant but had received brentuximab. KEYNOTE-204 demonstrated in a randomized controlled trial that pembrolizumab was superior to brentuximab, even in patients who were receiving this as their first treatment for relapse or progression, so second-line therapy, and sort of moves this up in the treatment algorithm to be the preferred choice after the failure of primary therapy in the patients that are not transplant eligible, and then for subsequent patients, in patients who have subsequently relapsed post-transplant failure. So the approved indications for checkpoint inhibitors initially have been established in patients that have developed disease progression post-autologous stem cell transplant, as well as in some circumstances for patients with relapsed disease who are potentially ineligible for autologous stem cell transplant. And previously, patients would have needed to have received brentuximab vedotin in general because that was an FDA-approved agent for that setting. With the newer data, again, the key point to highlight is that in a comparative trial, pembrolizumab has been shown to be superior to brentuximab vedotin and thus could be considered earlier in the treatment course.